Hello, my name is Marie Walker. I'm happy to have you here with me this evening as I go through the fourth of my four-part series called Looking Ahead. Tonight we're going to discuss what really happens, the physical process of death, and body disposal options. This is a subject that makes many people very uncomfortable, and yet it's very important. It can save you literally thousands of dollars to think about it. And also, there are probably a lot of options available that you aren't familiar with and that you haven't even heard of that may be exactly what you want.
And over here, our bass player, the Duke of Spook, the Doctor Shock, man with no tan. Please say hello to Death himself, the Grim Reaper!
This parrot is no more. It has ceased to be. It's expired and gone to meet its maker. This is a late parrot.
Keep in mind, the root word of funeral is fun.
Bring out your dead! Bring out your dead!
What can we do for you, sir?
I'm after a funeral.
Boy, are you in luck.
Unfortunately, our only options are cremation and burial.
Green funerals.
Oh, brother.
No caskets, no toxic chemicals to leach into the soil.
Inhumement, entombment, inurnment, immurement. Some people just lately have preferred in sarcophagusment. It's very individual.
I don't want anybody to make a fuss. When I go, I just want to be stood outside in the garbage with my hat on.
I'm not gonna die. You see, I'm into this thing where if I get sick, real sick, where I'm about to go, they just take me away and freeze me.
Although he is certain to die, perhaps from a household accident, which account for 65% of all unnatural deaths.
All right, we did not die today. I call that an unqualified success.
You're all gonna die. What's wrong with it?
I'm dying too.
You're going to die.
Prepare to die.
Grover wanted a Viking funeral.
Mills, tell him about the Viking ceremony.
Oh yes, the Vikings used to put the carcass on a boat and light it ablaze as it was cast out to sea.
That's exactly what I wanted. Something dramatic.
In the same way, every birth is different, but there are milestones that are usually passed in the same order, which lead us to know what to expect. Every death is both different and similar. Death comes in two forms. Unexpected, which makes up about 10% of all deaths, and it can include accidents, sudden illnesses or medical conditions, suicide, and overdose and substance abuse. It obviously contains many very painful and difficult and traumatic ways of death. Expected deaths have their own different types of pain, and they include age and terminal illness. In the United States, heart disease and cancer account for over half of all the diseases that occur each year. But the next leading cause is unintentional injury, with lung disease, stroke, Alzheimer's disease, diabetes, influenza and pneumonia, kidney disease, and suicide as the rest of the top 10. Remember, the scythe is purely symbolic. If anyone puts up any resistance, use this. Researchers at the University of Bath did research on traumatic deaths and how the first responders' responses made the family's grief and trauma better or worse. They issued a set of recommendations to help improve their responses and to assist people in their healing journey. These guidelines are not just for emergency personnel. They're good reminders for all of us. They begin with, always show kindness and compassion when interacting with a bereaved person. First impressions make a huge impression and can greatly help or hinder a person's response to grief. Think about the language you use. Avoid using labels like addict. Instead, talk about drug use and alcohol use. Use language that mentions the person before describing their behavior. Avoid saying, as always, I know how you feel, or you shouldn't blame yourself. Do not tell another person how they ought to be feeling. Allow them to have the reality of their own pain. Treat every bereaved person as an individual. Do not make assumptions about the person who died, or about how this kind of death may affect those left behind, or how they will react. Whatever your role is, do what you can to protect the bereaved person's well-being in a difficult and stressful situation. Do not be afraid of speaking to them about the death. It is often worse when it is not acknowledged. Ask the bereaved person what will help and what they want of you, and be willing to really, really listen without putting in anything to make you feel better. Be aware of and work with other organizations that deal with traumatic death so that you can advise bereaved people about where they might find help and support. Advise them on what the next steps will be, especially if there's something unfamiliar like a postmortem, an autopsy, an inquest, or a police investigation. Those are good pieces of advice for everyone, because we will all have to deal with a traumatic death at some point, probably in our life. There are many hardships that are associated with expected death. We can't say one form of death is harder or more painful than another, because this isn't a contest. It's not about who has the most pain. The pain is different, the hardships are different, but they are just as real and need to be dealt with just as lovingly and as carefully. Some of the hardships in an expected death might include financial hardship, not only medical bills, but nursing or caregiving help, having home modifications, having a special diet, or long-term dietary restrictions. There can also be pre-death grief, which can include mourning changes in the personality of the person or in the relationship that you had, mourning for lost opportunities and lost capability for the person that they used to be, mourning the loss of the person that you used to know. Dementia, particularly, is often called the long goodbye. And because of this, many times in this slow process, it allows so much of the grief to be processed that sometimes people are judged for not mourning enough or not grieving correctly, which can add useless guilt and hardship on top of an already difficult situation. Respect where they are and give them the benefit of their own pain and their own reality. Remember that caregiver exhaustion is a very real and difficult problem. Being a caregiver for someone at the end of life can be both physically and emotionally exhausting. Accept that there may be no perfect death. It might not be the good death that you hoped for or that you envisioned, but just do the best that you can for the one that you love. The pain of losing someone close to you may be softened a little because when you were needed, you did what you could. In this Pearls Before Swine cartoon, Rat is reading the newspaper, and he says, "Why do all of these obituaries always say that so-and-so passed away peacefully?" And Goat says, "What do you mean, why? Because the person died peacefully." "Yeah, well, when I die, I'm going to go out punching nurses and doctors just so finally someone can say he passed away violently." What a goal. Bring it on, death. It's definitely one way of looking at it. Discuss more of the dying process, the physical process of what actually happens as the human body shuts down. It's important to know that end-of-life care is the term that is used to support describe the support and medical care that's given in the time surrounding death, whether that is hours or months. It is not just a few moments before breathing ceases. It can be for a very long time. And people often live with one or more chronic illnesses and need a great deal of care for days, weeks, even months, or sometimes years before death actually comes. One of the problems that increases the stress of this situation is that many doctors are notoriously bad at breaking the news. And they try really hard to soften it or even to avoid it so that they don't have to break it to someone. However, clear communication and being willing to ask hard questions can help you make more informed decisions. If you have a doctor who is willing to say something like, "I'm afraid the news is not good. There are no other treatments for us to try. I'm sorry." There can be some grief as it closes the door to the possibility of a cure. But the realization that everyone will die, that we can ease the stress and hardship of that transition, changes the need but does not end the necessity of medical support and of support and involvement from family and friends. Death is a very personal journey which everyone approaches in their own unique way. While some things are common, nothing is concrete, and nothing is set in stone. Many of the parts of the journey of dying begin several months prior to death, while others occur in the last few days, and sometimes in the last few minutes of life. And just like with birth, there are milestones along this journey, but not everyone will stop at each milestone. Some people may only hit a few, while others may stop at each one and take their time along the way. Some may take months to reach their destination. Others will take only days. The dying person may experience reduced appetite and weight loss as the body begins to slow down. As systems shut down, the body doesn't need the energy from food that it used to. They aren't hungry or thirsty. But it's important for caregivers to realize that they're not suffering in any way by not eating. In many cultures, food is equated with love, and it can be a great emotional hardship when food is not wanted. But when we realize that the body is shutting down and it cannot process the food anymore, it can ease the stress for the caregivers. It is important to realize that you can offer, and if they are hungry for something, you are welcome to give it to them. Follow their lead. Follow what they want. They aren't hungry or thirsty. They're not suffering in any way by not eating. It is an expected and even a necessary part of the journey. So always follow their lead on what they want to eat and drink. The dying person may be sleeping more, and they may not engage in activities that they used to enjoy. The body does a wonderful thing during this time, as altered body chemistry produces a mild sense of euphoria. As they do brain scans, the brain is flooded with chemicals that make the person not suffer nearly as much as it would appear from the outside that they are. The dying process often accelerates in the last 1 to 2 weeks of life. It can be frightening for families. The mental changes especially can be disturbing to family members. Don't correct your loved one if they tell you things that don't make sense. Just listen gently and support them in their thoughts. If they claim to see loved ones who have died, simply let them tell you. We really don't have a way to know if these are hallucinations or if our loved ones have seen something that we cannot see. So simply love them and accept what they're saying. Don't worry that they are sleeping most of the time. Disorientation is common, and altered senses of perception can be expected. Family members should not be overly concerned by these changes. They are a normal part of the process. Sometimes the dying experience delusions such as fearing hidden enemies or feeling invincible. They may experience hallucinations or visions. The person may pick at their sheets and clothing in a state of agitation. They may talk about needing to pack or get tickets for a journey. Their movements and actions may seem aimless and make no sense to observers, but these are all common parts of the process of moving further away from this life on Earth. Physical changes may include the body having more difficulty maintaining itself. This means that your loved one may need help with just about any form of activity. They may have trouble swallowing medications, or they may refuse to take medications that have been prescribed. If they were using pills to control their pain, talk to the doctor about changing to liquid morphine at this time. There are signs that the body may show during this time. Their body temperature may lower by a degree or more. Their pulse may become irregular, and it may slow down or speed up. Skin color changes as circulation is diminished. It is often more noticeable on the lips and the nail beds as they become more pale and bluish. There's often increased perspiration. Breathing changes occur and often become more rapid and labored. Congestion may also occur, which causes a rattling sound or a cough. Speaking decreases and eventually ceases altogether. Periods of quietness may be interrupted by sudden movements of a person's arms or legs. They may become responsive, less responsive, but they can still hear you. The last couple of days before death can sometimes surprise family members, as often the dying individual may have a surge of energy as they get closer to death. They may want to get out of bed. They may want to talk to loved ones or eat something after days of no appetite. If the loved ones take this increase of energy to be a sign that the person is getting better, it can be very painful when this energy rush leaves. That is one reason why it's so important to know that this is common and is usually a sign that a person is moving towards death rather than away. Sometimes this surge of energy may be quite a bit less noticeable, but it is usually used as a dying person's final physical expression before moving on. The energy surge is short, and afterwards the previous signs of death become more pronounced. Breathing becomes more irregular and often slower. Sometimes they have Cheyne-Stokes breathing, which has rapid breaths followed by periods of no breathing at all. Congestion in the airway can cause loud, rattling breathing. This change in breathing can be very uncomfortable for loved ones, but it does not appear to be unpleasant for the person who is dying. The person may become unresponsive and may have their eyes open or semi-open without seeing their surroundings. But it is widely believed that hearing is the last sense to go, so it is recommended that loved ones continue to sit and talk with their dying loved one. It is important. And it is important to remember that what you say will stay with you even as they are passing. Eventually, breathing will cease altogether and their heart will stop and death will have occurred. It is important to realize that bodies are not scary or contagious. In the case of a 90-year-old grandmother who just died of congestive heart failure, of all the bodies in the room, hers is the least contagious. She isn't sneezing or coughing or touching things. The bacteria in her body aren't being passed on to the living. If the person didn't die from Ebola or something really traumatic, you won't get what they had, even coronavirus. It's important to remember that for thousands of years, we took care of our own dead. And the idea of what we now consider a traditional funeral is only about 150 years old. Embalming came into fashion after the Civil War when there were lots of bodies that needed to be transported a long way home. Gradually, undertakers concentrated on rebranding themselves as members of the professional class aspiring to be viewed on the same plane as doctors and lawyers who had recently had their own transformation, and not as trade laborers. Part of this was claiming anatomical expertise, and they promoted themselves as the guardians of public health. Both of those ideas are constructs that were strategically crafted to influence consumer perception, leading the public to believe that every dead body poses a risk to public health and that highly specialized care is required. And neither of those things is true. When someone is dying, pain control is very important. Gradual death on its own is not painful. However, if they had a disease that caused pain before, it will still continue to cause pain. And it is very important to treat that pain and to be very careful to stay ahead of it. Don't be afraid of giving as much pain medicine as is prescribed by the doctor, because pain is easier to prevent than to relieve, and severe pain is hard to manage. Try to make sure that the level of pain does not get ahead of the pain-relieving medications. Make sure that you tell the doctor or nurse if the pain is not controlled, because medicines can be increased or changed. Remember that for the person who is dealing with severe pain, the struggle with pain can be draining, and it can make it hard for families to come together in a meaningful way. Pain can affect mood. Being in pain can make someone seem angry or short-tempered. And although it is understandable, irritability resulting from pain might make it hard for the person to talk and can make it harder for them to share their thoughts and feelings. If you need help, ask for a consultation with a palliative medical specialist who has experience in pain management for seriously ill patients. They specialize in this, and they can help you. Television and movies have given an artificial view of CPR, resuscitation, and life support. The reality is that older patients who require prolonged mechanical ventilation after high-risk surgery have high burdens of treatment and have a substantially higher risk of dying in the next year. The National Institutes of Health feel that this difficult trajectory should be considered in surgical decision-making and has important implications for surgeons, intensivists, and patients. Knowing what the realistic risks and expectations are can affect your choices as a decision maker. Choosing quality of life over quantity of life is a decision that needs to be made before it is needed, and it needs to be documented and talked about. Patients and their families are often presented with the vitally important code conversation when they go in for a medical procedure. If your heart stops or you stop breathing, do you want us to do everything? Dr. K.V. Scruggs says, for a doctor, this is a lazy way of asking, would you want to be resuscitated, without explaining exactly what that entails. But what patients often hear is, do you want us to do everything or nothing? Or worse, I think you might die during this hospitalization. The reality is that neither of those things is what the physician is really trying to express with this question. But it takes time, thought, and energy, as well as the realization of need to unpack a phrase that they understand and they're used to, the patient may not be. First, there is a lot that the medical community can offer in the way of treatment that is short of resuscitation. Often, treatments are able to circumvent the need for resuscitation altogether. But even if death is unavoidable, there is much that can be offered both to patients and to their families to reduce suffering and provide support. We as a society often equate doing everything with showing our love. I will never let Dad die. However, many times nothing could be further from the truth. Dr. Scruggs says, as people age and their chronic illnesses progress, quality of life rather than quantity of time should become the central focus. Comfort care should address all of these areas. pain management, breathing issues, which can often be alleviated by the use of oxygen, a gentle fan, and/or a humidifier placed near the patient, skin irritation, which should be carefully monitored for and addressed if it occurs, digestive problems, especially the discomforts that are associated with constipation from pain medication, temperature sensitivity, fatigue, because the medically frail are easily fatigued, and it can be very, very wearing on them. Complete end-of-life care also includes helping the dying person manage mental and emotional distress, resolve problems before they become serious. It is just as important to treat emotional pain and suffering as physical pain. Encouraging conversations about feelings might help, as can seeing a qualified therapist. Doctors may feel helpless because they can't cure their patient. Some seem to avoid a dying patient, and this can add to a dying person's sense of isolation. If this is happening, discuss your concerns with family, with friends, or with the doctor. It's important to remember that the simple act of physical contact, holding hands, a touch, or a gentle massage, can make a person feel connected to those he or she loves. It can be very soothing. But remember to make sure that you warm your hands by rubbing them together or running them under warm water before you do. It's important for people to understand what palliative care and hospice care are. Palliative care is medical care that is focused on quality of life, not extending life. Everyone needs to understand why palliative care hospice care exist and how they can bless people during the hardest parts of their lives. Palliative care is specialized medical care for people with a serious illness. This type of care is focused on providing relief from the symptoms and stress of a disease. The goal is to improve quality of life for both the patient and their family. A patient can be in palliative care for years or decades, depending on what issues they're dealing with. Hospice care is specialized palliative care for patients who are entering the final stage of their life. When their diagnosis gives them less than 6 months to live, they might be recommended for hospice care. Its focus is on helping the patient and their caregivers and families have support in all aspects of the dying process. Many hospices have community outreach programs that provide help, comfort, and support, even for non-hospice loss. My local hospice offers support groups for many types of loss, and even a summer day camp for children who have experienced loss to have fun and learn coping skills. All hospice is palliative, but not all palliative care is hospice. As uncomfortable as it may seem, the best gift a person can give their loved ones is communication. Clear and honest communication about how you want to live, how you want to die, what you want to happen after your death, including how your body is disposed of and what your memorial options should be, is a wonderful gift for them. These talks should happen more than once. It's important for all family members to respect the wishes of the others, even when those choices are not what you would personally choose. When you have a foundation of clear communication, you can feel secure making decisions, knowing that you are honoring and fulfilling their desires. Every adult should have a living will and a durable healthcare power of attorney that states what procedures they do and do not want and under which conditions. And their family should know what it contains and how to access it. Another name is added to the National Transplant waiting list every 10 minutes.